Let's look at conduct of normal spontaneous labor. And they very well could have on the exam a scenario where they describe what's happening and then ask, what will you do? And your response will be nothing. Everything is going as it should. Here's our case. 20-year-old Gravida 1 comes to the maternity unit at 39 weeks, complaining of regular uterine contractions every 3 minutes for the past 6 hours, becoming more frequent. She denies any vaginal fluid leakage. Membranes are intact. Vital signs are stable. On pelvic exam, cephalic presentation, head is down, -1 station, cervix is 5 centimeters dilated, 90% of face, soft anterior. Electronic fetal monitor, baseline fetal heart rate is 135 a minute, good variability, frequent accelerations, no decelerations. This is a wonderful scenario. I pray this will be your experience. How do you manage a normal labor? All right, pre-admission. We generally don't want to admit the patient in the latent phase. Why? It could take up to 20 hours in a primipara, up to 14 hours in a multipara. Why should she be in the hospital when she can be at home with people who love her? Now, it's not that we don't love our patients, but not the same. Stay at home until she is in active labor. The exception to that would be if premature rupture of membranes has occurred. Now we're concerned about infection, and we're going to start oxytocin. Please make sure that it is cephalic presentation. In teaching hospitals in July, the new interns come on, and this happens all the time. The intern examines a patient, isn't really compulsive, doesn't recognize what the presentation is, and 6 hours later, all of a sudden people say, oh, the baby's breech. Then she ends up with an emergency cesarean, and she says, did I have to labor all this time? Make sure that it is cephalic presentation. We typically will start an IV line, good isotonic fluids running. We want to avoid dextrose because we don't want to get high levels of glucose in the baby. Clear liquids as tolerated by the patient. Maternal position as comfortable. If she wants to sit down in a chair, that'll be fine. If she wants to lay down. We encourage the lateral recumbent position. Why is that? Because we want to make sure that there isn't the weight of the placenta on the inferior vena cava, which can result in decreased cardiac return. The average major teaching hospital typically sees a 4% jump in its risk-adjusted mortality rate in the summer, and that's because of interns. That's what you're going to be, hopefully, not too long from now. All right, overview. First stage of labor. We typically have continuous electronic fetal monitoring of the fetal heart rate. Labor progress is documented by appropriately spaced vaginal exams. Let's say that she comes in at 4 centimeters, and she's going to have a 4-hour second stage, first stage, active phase. How many vaginal exams will she have? Probably 2 or 3, that's all. Amniotomy, rupture the membranes as appropriate. Analgesia, PRN, as needed. Some patients will say, I want to feel every contraction. And I say, I think we can arrange that. Other patients say, when I come through the door, hit me with the epidural. Which is the best? I think it's a very personal decision. Second stage, mother pushes with contractions. Episiotomy is not routinely done. We'll talk about that later, only if indicated. In the third stage of labor, spontaneous placental separation. As the uterus contracts, we'll give IV oxytocin to help the uterus to contract, and the placenta will come out. Then we'll typically observe the patient for a couple of hours after delivery to make sure there is no postpartum hemorrhage and to make sure that she doesn't develop preeclampsia, which can develop in labor and postpartum. Okay, that's the end of normal spontaneous labor.